Assalamu alaikum everyone and welcome back. This is a continuation of our previous lecture on the B lymphocytes and the antibody mediated immunity. We discussed the very basic details last time, and today we will go on to add some more detail. Okay, we will particularly address the various confusions surrounding the B lymphocytes and the antibody mediated immunity, so that by end of this lecture you will have answers to the frequently asked questions in this connection. Okay, so the first such confusion is we keep on telling you that the B lymphocytes, when activated, transform into plasma cells, and the plasma cells then secrete antibodies. Okay, at the same time, elsewhere in your textbooks they keep on telling you that the antibodies are embedded on the surface of B lymphocytes. Now, whether they are actually embedded on their surface or they are actually secreted in circulation remains a source of confusion. Actually, both these statements are correct, and to understand it, we need to understand the evolution of B lymphocytes in their bone marrow and still later in their pre-processing sites. Okay, so to begin with, they're produced from the lymphoid stem cells in the bone marrow, and in the bone marrow they first form the pre-B cell and still later B cells. Okay, however, at this stage they are quite immature and they don't express any immunoglobulins on their surface. Okay, from the bone marrow they move on to their pre-processing sites in the liver in mid-fetal life and still later in late fetal life, and after birth this pre-processing occurs in the bone marrow. In the here at their pre-processing sites they grow further and they differentiate slowly and gradually into more mature B cells. This is here at this level when they express surface immunoglobulins, that is either immunoglobulin M or D, or they may have both simultaneously. Okay, and still later when they are from these sites they move on to their storage sites and keep waiting for their possible encounter with the antigen against which they have specific reactivity. Okay, when they have such encounter they are activated and transform into plasma cells. The plasma cells then secrete more and more antibodies. So this is here at this level, at the level of plasma cells, when they begin to secrete antibodies. Okay, and those antibodies are antigen specific and they are actually secreted in circulation. Okay, and when they are activated, some of them undergo a clonal expansion to form plasma cells, and at the same time some copies go on to make the memory B cells that repopulate the bone marrow and serve as a source of activation on re-exposure to the same antigen or microbe in future. Okay, so the question is, if they have surface immunoglobulins while they're still in their pre-processing sites, what is their function? Okay, and the answer is the B lymphocytes are antigen presenting cells. They need these immunoglobulins on their surface right here. They are actually embedded on their surface, and they serve as a source of binding with the antigen so that the B cells can be activated. Okay, so in any such case, immunoglobulin M or D are both expressed on their surface, embedded under their cell membrane whenever there is encounter with that specific antigen against which they show specific reactivity that causes some activation. Okay, slight activation of the B cells, that binding of the antigen with the antibody expressed on the surface causes these antibodies are actually connected with other transmembrane protein domains that pass on the signal to the cell interior and activate the intracellular signaling pathways. Okay, at the same time this whole antibody antigen complex is internalized so that we now have the whole antigen antibody complex within the B lymphocyte. Okay, still later the B lymphocytes go on to express this antigen here on their surface in association with MHC proteins, and as we discussed earlier, they are presented in association with MHC1 proteins if they have to activate the cytotoxic T cells. For activation of the helper T cells, the antigen is expressed in association with MHC2 proteins and which binds with the T cell receptor. Okay, so that the helper T cell can be activated. At the same time, in addition to this interaction, there is some physical interaction at other levels as well. For example, the B cells interact with their surface markers, the B7, with the T cell through their surface receptors CD28. Okay, similarly here we have the CD40 on the surface of B lymphocytes that interacts with the CD40 ligand on the surface of T cells. Okay, and we need these interactions at all these levels, at multiple levels, so that the helper T cells can be activated. And the helper T cells, once activated as a result of these interactions, go on to release or secrete various chemical mediators we call lymphokines. There are so many of them, but the most important ones are the interleukin 2, interleukin 4, and interleukin 5. Okay, among these, the interleukin 2 causes stimulation of the T cells themselves, that is secreted for self-stimulation, while interleukin 4 here acts on the B cells. It causes the proliferation or clonal expansion of the B cells so that they can increase their numbers. Okay, while the interleukin 5 causes the B cells to differentiate. Okay, so differentiation is in a way attaining sufficient maturity and activation for the B cells to become antigen specific. So what you need to remember, IL-2 for self stimulation of the T cells, interleukin 4 for proliferation, growth and proliferation of the B lymphocytes, and interleukin 5 for the differentiation of B lymphocytes. Okay, at the same time, the interleukin 4 here not only causes expansion, it causes class switching of antibody formation towards IgE. Okay, so that these activated B lymphocytes can switch their antibody formation towards IgE. Similarly, the interleukin 5 causes IgA class switching. Now that is a bit complicated concept to be discussed at this level, but what you need to know, the B cells interact with the T lymphocytes through these receptors. They express the antigens on their surface in association with class 2 MHC proteins. They interact through CD40 and the surface receptor B7 so that the T cell can be activated, only so that the T lymphocyte can cause further activation of the B lymphocyte through those specific interleukins. Okay, the activated B cells in their naive state, when we call them naive when they are sufficiently mature but they don't have that encounter with the specific antigen against which they show specific reactivity. Okay, so in the activated but naive B cells, the antibodies are embedded on their surface and they serve to bind antigens so that the B cell can be activated through this whole process. Okay, once they are activated, they transform into plasma cells and only then are they able to secrete those antibodies, okay, in circulation. Still later, there is a common confusion among students that the antibodies will necessarily protect against the offending or invading antigen or microbe. Okay, they are actually meant for protection, but they do not necessarily offer such protection. For example, we have the We have these antibodies against the human immunodeficiency virus and the hepatitis C virus. They are actually formed, but they don't offer protection or protection against the microbe or its elimination. They are merely there, and we use them for diagnostic purposes. Okay, so they are meant to protect, but they do not offer protection necessarily. Okay, still later, it requires quite some time for antibody formation. Okay, and in general, it usually takes 1 to 3 weeks on average for the B lymphocytes to be activated enough to cause antibody formation. Now, this is just a rough estimate. This duration varies from case to case, but in general, it usually takes 1 to 3 weeks. Okay, and in general, the first antibodies formed are the IgM type, and still later they form IgG, and we use that clinically for differentiating between acute infections and chronic infections. Since the IgM antibodies are formed acutely, first we use them as a marker of acute infection, IgM for acute infection, okay, and IgG for chronic infection. Okay, now again, the cutting line, the cutoff between acute and chronic varies from case to case, but in general, anything this stays for days to weeks is what we call acute. And if it lasts for more than 4 weeks, this is where in most cases we label it as chronic. However, there is significant variation. Okay, there are problems with the antibodies themselves. Okay, while we are treating patients, we not only treat their illness, but we take care of their economy as well. So we need to make sure if a person presents to us early, say they are ill for 1 to 2 days, okay, and we order an antibody test, so there is a chance for the antibody test to be negative because it is too early for the B lymphocytes to be able to secrete or synthesize those antibodies. Okay, in such cases we may need to go for repeat testing usually at 6 weeks interval. Okay, so we need to take care of this fact as well. As a general rule, the IgM antibodies suggest an acute infection, while the IgG antibodies suggest a more chronic disease process. Okay, but there is one exception to this rule, and that is related to the memory B cells that express IgG. So, for example, a patient approaches us with symptoms spanning over a few days or 7 to 10 days at most. We order a certain antibody test and we get IgG positive antibodies. Okay, so it used to be a source of confusion for me in my early clinical practice, but still later I came to know that is the second exposure to the same antigen. The patient may have been previously exposed to the same disease process, and on re-exposure it is possible for those patients to make IgG earlier than normal, so that even the disease has been there for say few days and we get IgG positive. So it is possible for IgG antibodies to an acute infection as well. Okay, one more problem with the antibodies is their cross-reactivity. Now, by cross-reactivity, what we mean, antibodies formed against a certain antigen or a microbe go on to react against closely related other antigens. Okay, and it has two types of problems for us. And the first such problem is we may get false positive results even when the disease is not there. Okay, for example, we used to order the historical Vidal test and typhidot test for diagnosis of enteric fever or the typhoid fever. Okay, but they have been abandoned for a few years because we would get false positive results even when the patients would not have typhoid or enteric fever, they would have antibodies against a closely related other antigen, and we would get false positive results for typhoid fever. And that used to misguide us on such a large scale that those tests were finally abandoned. Okay, and there is one more implication of the cross-reactivity, and that is autoimmunity. Antibodies formed against a certain antigen may go on to develop other closely related antigens, and one such example is rheumatic fever. We normally have streptococcal infection of the throat with certain strains of streptococci. The immune system makes antibodies against those streptococci, but owing to structural resemblance, those antibodies go on to attack the cardiac cells because they have M proteins, and the M proteins show some structural resemblance with the streptococcal antigens. So here the antibodies that were meant to eliminate the invading streptococci go on to cause problems or reaction against native antigens. Okay, so cross-reactivity may cause false positive results, they may cause autoimmune reactions or disease. Well, while we earlier discussed some of the B cell receptors and surface markers which are functionally important to us here in physiology because they determine interaction of B cells with the T cells for their own activation. But here we have some more surface markers on the B cells. All the B cells, irrespective of their stage of differentiation, express CD19, CD24 and CD72. While the mature B cells, in addition to those, also express CD20, CD21 and CD40. Okay. Similarly, the activated B lymphocytes express CD23 in addition to all these surface markers. Now I'm talking about these surface markers just to be able to answer one of my students' question. Bahish Rahat, if you're listening to me, these surface markers are not just limited to B cells. For example, the CD19 is expressed on many of the follicular dendritic cells as well. Similarly, the CD24 is expressed on granulocytes and many of the epithelial cells in the body. And same is the case with CD21 and 40, which are expressed on some of the epithelial cells in the body. So mere expression of any one or more of these surface markers doesn't make a cell a B cell. Okay? It is possible for other cells to have these surface markers, and this is what we mean by significant overlap. Well, here we have a good news for many of you. Most of what we discussed today is what we call extra detail, and you're not supposed to know many of those extra things right at this stage. Okay, if you know the very basics like we discussed in our previous lecture, you are on the safer side. We don't expect you to know those extra things. Okay, and this news might be somewhat unpleasant for a few of you, but those ambitious guys, particularly the bookworms type, if you go for that extra detail, it definitely adds to your impression, but you won't get any extra marks. Okay, at the same time, we feel somewhat bad for you because we know that extra detail in every topic comes with a price tag. Okay, to be able to master that extra detail, you may have missed your morning walk, your evening game, a good night's sleep, or a part of that quality time that was meant or supposed to be spent with your family and friends. Okay, so at this stage we want you to work harder and smarter. We don't discourage you to go for extra detail, but you will have your time. These subjects will be taught at some higher level, immunology, pathology and medicine part of it. Okay, so I wish you stay happy, you work hard, you work smart, and God bless you all.